All right, everybody. So this is the third recording for Module 6, Part 2. We're going to be talking about COPD. About 16 million people have COPD in the U.S. It is the third leading cause of death, with greater than 120,000 people per year. Caucasian white people have the highest incidence despite higher rates of smoking among other ethnic groups. And Hispanics have a lower death rate related to COPD than other ethnic groups. Some gender differences: it's more common in men. Men have poorer response to oxygen therapy. COPD is increasing in women due to smoking and increased susceptibility. More women die from COPD, and women have a lower quality of life, more exacerbations, and increased dyspnea. Previous definitions of COPD have encompassed terms like chronic bronchitis and emphysema. While both of these conditions share characteristics with COPD, neither can be considered COPD on its own. Chronic bronchitis is characterized by a persistent cough and sputum production lasting for at least 3 months and 2 consecutive years. It stands as a distinct disease entity that may occur before or after the onset of airflow limitation. Emphysema involves the destruction of alveoli without fibrosis, representing only one of the various structural abnormalities observed in COPD. It is considered to be preventable, treatable, and often progressive, characterized by persistent airflow limitations. The chronic inflammatory response in the airways and lungs is primarily caused by cigarette smoking or other noxious particles or gases. Exacerbations and other coexisting illnesses contribute to the severity of the disease. I don't believe all of the risk factors for COPD are on this slide, but this is a fairly comprehensive list. So, of course, cigarette smoking is one of the biggest risk factors for COPD. Infection, severe reoccurring respiratory infections in children, HIV and tuberculosis, asthma, air pollution, occupational dust and chemicals, genetics. Again, we have that alpha antitrypsin deficiency that we had talked about back in asthma, and then aging. It's not really clear if aging results in COPD or if it's actually just the cumulative effects of the exposures to the noxious chemicals and that causes it. So normal aging is a little similar to COPD. We do have the loss of elastic recoil and decreased compliance. There are changes in the thoracic and rib cage and decreased functional alveoli and surface area for gas exchange. Cigarette smoking. 20% of smokers are going to get significant airway obstruction from smoking cigarettes. COPD should be considered in any person who is over 40 with a smoking history of 10 or more pack years. The effects on the respiratory tract include hyperplasia of cells, the goblet cells, which causes increased production of mucus and reduced airway diameter, lost or decreased ciliary activity, and abnormal distal dilation and destruction of alveolar walls. Chronic enhanced inflammation resulting in remodeling, and oxidative stress. Now, passive smoking, that what we also have called secondhand smoke, where you're having that environmental smoke, also can cause decreased pulmonary function, increased respiratory symptoms, and increased risk of lung and nasal sinus cancer. COPD pathophysiology is affected by several things. It is characterized by chronic inflammation of the airways, lung parenchyma, and pulmonary blood vessels. One of the big features of this is that airflow limitation that's not reversible during forced exhalation, and that's secondary to loss of elastic recoil and airflow obstruction due to mucus hypersecretion, mucosal edema, and bronchospasm. The disease progresses by worsening of abnormalities in airflow limitation, air trapping, and gas exchange. And remember, we talked about gas exchange as when we have a low oxygen saturation, or PaO2. And in severe disease, we'll see pulmonary hypertension and other systemic manifestations. It's also noted that there will be impaired or destroyed lung tissue existing alongside normal tissue. So this is just showing that pathophysiology of what I was talking about, showing this inflammation and the things that are causing the inflammation, that peripheral airway, that remodeling that's happening, the parenchymal destruction, and then the pulmonary vascular changes. And all of those end up causing all those other things that we had talked about. So the primary issue is inflammation in COPD. That inhalation of noxious particles and gases results in inflammation, which results in damage to the lung tissue and impaired normal defense mechanisms and the inability to repair. The predominant inflammatory cells are neutrophils, macrophages, and lymphocytes, and oxidants contribute to structural destruction. The main characteristic of COPD is the inability to expire air. One of the things why we see that barrel chest. The main site of airflow limitation is the smaller airways. The peripheral airways are obstructed and trap air during expiration, which results in that increased residual volume. Again, that results in that barrel chest. The patient becomes short of breath and has limited exercise ability as they try to inhale against the overinflated lungs. So in this image, it's just showing you how the walls are destroyed. And if you remember, normal alveoli are really small, and this air trapping causes something that's either called bullae or blebs. As I mentioned earlier, we do have the excess production of mucus and the cough, which we had talked about all of this beforehand. Not all patients with COPD do have sputum production, though. It is a systemic disease as a result of chronic inflammation, and frequently you'll see these patients having cardiovascular diseases as well. Other things you might see are osteoporosis, diabetes, or metabolic syndrome. And we'll be talking more about diabetes and metabolic syndrome in a future module. Pulmonary vascular changes, again, we have that vasoconstriction of pulmonary arteries due to the hypoxia. We'll see vascular smooth muscle of the pulmonary arteries thicken with advanced disease, and this results in that pressure in the pulmonary circulation increasing. That results in that pulmonary hypertension, which can also then lead to that right ventricular hypertrophy, which results in that cor pulmonale or right heart failure. At this level, you do not need to know the signs and symptoms of pulmonary hypertension or the cor pulmonale. You'll learn about those more in a future session, future med-surg course. The signs and symptoms of COPD. So it does develop slowly over time. Diagnosis is going to be considered with a chronic cough. It starts out intermittent. Sputum production, again, not everybody has that. The shortness of breath that occurs with exertion, we also call that DOE, dyspnea on exertion, and that gets progressively worse as they continue to move and as the disease progresses. Also, we have to consider the exposures to the risk factors. It is important to distinguish COPD from asthma, and Table 31.6 in your textbook does a really nice job in this. Now with the COPD, they're going to have chest heaviness, and they can't take a deep breath. They might be gasping, and you'll notice an increased effort to breathe. They even could be air hungry, and air hunger is something very difficult to watch in somebody. The symptoms are often ignored, and then patients do change their behaviors to try to avoid that shortness of breath. The shortness of breath usually prompts medical attention. Again, it occurs with that exertion in the early stages, and then it's even present at rest with advanced disease. So other things you'll notice on a patient who has COPD is that they're a chest breather versus abdominal breather. They do use accessory and intercostal muscles, and they have inefficient breathing. There may be wheezing and chest tightness, fatigue, weight loss, and anorexia. And remember, anorexia is just that decreased appetite. Prolonged expiratory phase, decreased breath sounds, potentially wheezing, the barrel chest. They may be sitting in that tripod position, and we talked about that. That is one of the ways they help to expand that AP diameter and help breathing. And the pursed lip breathing, many of the patients don't even have to be taught this. They naturally do it. But if they're not doing it, it is something we need to teach them. And then peripheral edema would be noted if they do have that right heart failure, which is not part of our exam at this point. Other things that we'll notice with COPD is that hypoxemia, that PaO2 less than 60, and the oxygen saturation less than 88. And we'll talk more about why 88 is where we get concerned with the COPDer. They'll have that hypercapnia, the PaCO2 greater than 45. And again, this is about that gas exchange. They have problems getting rid of that CO2 and bringing in the O2, why we see that hypercapnia. They may have increased production of red blood cells causing that polycythemia, and that's because the body is like, I don't have enough oxygen, so it's trying to increase the RBCs to help compensate for the issues with the oxygenation. And then hemoglobin concentrations can reach as high as 20 grams per deciliter or even more. Now, bluish red color of the skin can be secondary to the polycythemia and cyanosis. Again, I mentioned these complications with COPD, that pulmonary hypertension or cor pulmonale, which is just right-sided heart failure when it comes from a lung issue. These are not going to be tested other than knowing that they can be complications. You do not need to know the signs and symptoms of those. You'll learn those in another med-surg course later on. So during an acute exacerbation, the patient's going to have obviously worsening of the respiratory symptoms. So again, that's going to be increased respiratory rate, increased sputum, increased sputum looking purulent, potentially that green, nasty looking stuff. They're going to go from just the regular fatigue to malaise, potentially unable to sleep, and that can be secondary to that shortness of breath. Depression, confusion, again, that low hypoxia, that decreased exercise tolerance, wheezing, and potentially a fever. One of the common causes from their exacerbations is that they either have a bacterial or a viral infection. And this increases more often as the disease progresses. At this point, the patient may be treated as an inpatient or outpatient, and that's really just going to depend on the severity, depending on how low their O2 is, are they hemodynamically stable, what are their ABGs, and what do we need to do to get them safe. Treatments are going to include our SABAs, our short-acting beta agonist, and oral corticosteroids. Other meds could include those anticholinergics, antibiotics, diuretics, again, depending on what's going on. And then oxygen. We're going to prefer to do oxygen via nasal cannula. Again, one of the big things when you have a COPD, or if they're really holding on to that CO2, the non-invasive pressure support like BiPAP is one of the things that really helps a COPD patient who is struggling with hypoxia and the hypercarbia. So during an acute exacerbation, we really want patients to not wait too long, because if they wait too long, they could go into acute respiratory failure. They may need hospitalization for those acute exacerbation or complications. Again, that's that pneumonia, cor pulmonale, or acute respiratory failure. And the degree of the severity of the underlying respiratory problem needs to be assessed and determine what care they need. Now, there are a lot of different tests that can support a COPD diagnosis. Spirometry is the one thing that really confirms the diagnosis. And that's where you're going to have that inability to forcefully exhale. They'll also do chest x-rays looking for that barrel chest, looking for any pneumonia or other problems. Again, that serum alpha antitrypsin level helps to tell if there's a genetic issue. And when somebody has COPD, we actually do what's called a 6-minute walk test. That's where we'll walk them and have a pulse ox. And if they have less than 88% at rest, or even when they're walking, they will qualify for oxygen. And that's one of those Medicare requirements that you have to be under that 88. There are also other tests that we can do with somebody with COPD. The COPD assessment test known as the CAT test, or the clinical COPD questionnaire, the CCQ. You do not need to look into these. Just know that they're possible tests that they see how somebody's doing. Obviously, we're only going to do ABGs if somebody has a problem with it. And then sputum cultures and sensitivity are going to be if we're looking for somebody with an infection. So obviously patients with COPD are treated mostly as the outpatients. They do get hospitalized for those acute exacerbations or respiratory failure. We should evaluate for those exposures to those environmental or occupational irritants. Make sure that they're getting their influenza vaccine every year and getting their pneumococcal vaccine. And following smoking cessation, the rapid decline in lung function associated with smoking gradually decelerates to levels similar to those of non-smokers. The earlier an individual quits smoking, the less lung function is going to be compromised, and the quicker the symptoms, specifically the cough and sputum production, can diminish. So patients with COPD are going to need bronchodilators. Bronchodilators help to relax the smooth muscle in the airways. They improve ventilation of the lungs. They'll help to decrease that shortness of breath and increase their forced expiratory volume. Inhaled routes are preferable, and they'll get beta-2 adrenergic agonist, anticholinergics, or methylxanthines. And those are some of the medications that we've already talked about with asthma. And that's one of the nice things, that when you're learning asthma and COPD together, the medications and treatments are very similar. Now, with severe COPD and chronic bronchitis, the patient may be ordered roflumilast, which is the trade name for that is Daliresp, I think. And it's a selective phosphodiesterase 4 inhibitor, which helps to decrease the incidence of exacerbations with severe COPD. So there are some COPD surgeries that can happen to help with the breathing, but many patients are not going to be candidates for surgery. So their surgical therapy, there can be a lung volume reduction surgery where they're actually taking out the diseased tissue so the healthy tissue can work better. They can also do a bronchoscopic lung volume reduction where they actually do a bronchoscopy and they put multiple one-way valves into the airways, and that causes that diseased lung to collapse. The problem with this one is that a pneumothorax is a common complication. They can also do a bulectomy where they're removing one or more of the bullae to decrease that work of breathing. And then in severe cases, we could be looking at lung transplantation where they're doing a single or a double lung transplant. But again, not all patients are going to be surgical candidates. These are not something I would spend a lot of time memorizing. Just be familiar that these can help a patient if they're really in need. So oxygen therapy in a patient with COPD is really important to kind of know about. Obviously, it's used to treat hypoxemia. Our goal is to keep the O2 saturation greater than 90% during rest, sleep, and exertion, or the PO2 greater than that 60. The plan will be individualized, and it does help to improve survival. And so patients can either get high flow or low flow. Low flow is the most common. Low flow is mixed with room air, and delivery is less precise than high flow. High flow, fixed concentration would be with a Venturi mask. Humidification and nebulization, because oxygen has that drying effect on the mucosa and secretions. We generally use sterile distilled water, which gives the bubbles through the humidifier for somebody who's using oxygen all the time. Helps to decrease those nosebleeds and nose discomfort. So more about oxygen, we obviously want to teach patients no smoking or open flames. There is a thing called CO2 narcosis. And what happens is, for you and I who have healthy lungs, CO2 is what stimulates us to breathe. But with somebody who has COPD and they have been having this increased CO2 retention, their hypoxic drive is what gets them to breathe, which is why we have to give oxygen carefully to COPD patients. There's also the problem with oxygen toxicity when you get prolonged high oxygen, and that can cause severe inflammation to the lungs and actually damage to the lungs. Infection is common with oxygen. That humidity supports the bacterial growth. You can see them have Pseudomonas from that, and it's important for them to change out their nasal cannulas or what other tubing in that periodically per the recommendations. I believe it's usually monthly, so that they don't end up with infection. So oxygen therapy, again, they have to qualify for this. Short-term oxygen therapy is for up to 30 days. I have never really had somebody get oxygen therapy short-term. Most people have gotten it long-term. And so they should be using oxygen 15 or more hours a day. And they'll need a central source at home with a portable system. And so in this picture here, you'll see a compressor where they get that from the most of the time. And then they'll have to have something for when they leave the house. So long-term therapy at home, a respiratory therapist comes to the home and sets it up and gives the education. That's going to help decrease the risk of infection, teach them about safety issues. One thing that you might not think about is somebody who has oxygen on can't be blow drying their hair at the same time, right? That the risk of sparks from the hair dryer could catch them on fire, which obviously is not a good thing. We really want patients to try to remain active and travel, but it can be a little daunting for patients who have oxygen to try to figure out how they're going to get that to different places. So there are some breathing techniques that help patients who have COPD. The picture up here is that purse-lip breathing. So you're going to have them breathe in through their nose. I always tell them to smell the flowers and then blow out the candles. And we want that expiratory phase to be about double what the inspiratory phase is. We don't want them to be blowing out all the air with that. And then diaphragmatic breathing, I have a picture of this here. So they should breathe in and their belly should go out. And as they exhale, the belly should go in. And these are some of the ways that help them to improve their breathing instead of using those accessory muscles. Now, there are some airway clearance techniques that can be used with bronchodilators. And then huff coughing is one of the things that helps to get rid of secretions. And there is a table in your textbook that tells you how huff coughing works. I believe it's 28.2, but that seems wrong. I'm not sure. Other things that may help a COPD patient would be that chest physiotherapy, and that helps with excessive, difficult to clear bronchial secretion, postural drainage, percussion, vibration. There can be some complications of fractured ribs, bruising, and hypoxemia and discomfort. When you look at pictures of postural drainage, it's a little interesting. Basically, it's putting patients in all kinds of different positions that helps to assist gravity in getting rid of the secretions. And it can be done 2 to 4 times a day or even every 4 hours. And contraindications would be for traumatic brain injury, chest trauma, hemoptysis, heart disease, a pulmonary embolism, or unstable condition. And when I think about the severe patients with severe COPD, many of them, again, that have that severe COPD are not going to be able to tolerate some of the positions for that postural drainage. So this is a picture I found of that percussion, and you think about the person is using kind of a cupped hand, and they're kind of just pounding on the back. And that air cushion helps to facilitate the movement of that thick mucus. You may remember this as being one of the things they do with our cystic fibrosis patients when they have that thick mucus as well. The vibration helps to create that vibration, also helps to get rid of that secretions to the larger airway. And then there are some commercial vibrators that we'll see in a couple slides that do help with that too. Now this little device, the green one, it's actually called an acapella, but many people will just call it a pickle because it's green and kind of has the shape of a pickle. But it helps to kind of flutter in the chest, and it helps patients to really mobilize those secretions. And so that can, the patient can have that at the bedside. They don't need anybody there, and we can just instruct them to use it to help them with a cough. There are a lot of reasons why nutrition is really important with COPD. Because of the inflammatory problems, the increased metabolic rate, the decreased appetite, those all can cause malnutrition. And with somebody with severe COPD, weight loss is a predictor of poor prognosis. So some of the things that help to decrease that shortness of breath and conserve energy, we're going to encourage them to rest at least 30 minutes before eating, not to exercise for an hour before or after eating, and to use a bronchodilator before they eat. Using their oxygen may be helpful. We're going to want them to choose those high-calorie, high-protein, moderate carbohydrates, and moderate fats. Again, we never tell them to eat 3 big meals. It's going to be that 5 to 6 meals a day to avoid that bloating and feeling full early. They should also avoid foods that require a great deal of chewing because they're going to fatigue. Avoid exercise and treatments 1 hour before and after eating. Try to avoid those gas-forming foods. One of the first things I think of is like broccoli. And they should not drink fluids with their meals. That way they can take in more nutrition, food, and not filling up with their fluids. So we've already discussed most of the things on this slide. We want them to stop smoking, make sure that they're getting treatment for upper respiratory tract infections early, try to avoid infections, so that's that good hand hygiene, staying away from sick people, healthy weight, exercise, all the things that keep somebody healthier. Want to try and stay away from those pollutants or irritants. They need to get their vaccines. And then letting them know about that genetic link with COPD with that AAT deficiency. So some patients with COPD will go to pulmonary rehabilitation, which is they're going to get exercise and training and smoking cessation, nutrition counseling and education, and potentially even some internet programs. So that exercise training will help teach them to conserve energy. They sometimes have troubles with their upper extremities, so it may improve that muscle function and decrease that shortness of breath. It's going to help them to teach to modify their ADLs to conserve their energy, such as hair care, shaving, showering, and how to do the oxygen during the activities with hygiene. And somebody who should walk 15 to 20 minutes a day, at least 3 times a week, gradually increasing as their dyspnea allows them to. But of course, we want them to get adequate rest so that they are really doing that rest exercise balance. It's important to consider the psychosocial factors for somebody with COPD. Learning to live with this lifestyle challenge can be a challenge. They may be angry, they may deny it, they may be frustrated, loneliness, or guilt, especially if smoking is the cause. They may also have depression or anxiety, so it's really important that we get them involved in support groups, counselors, or cognitive and behavioral therapy, and the medications as appropriate, such as SSRIs or whatever will help with their psychosocial concerns. Now, patients with COPD do not have to give up sex. They just want to try to plan for their sexual activity when their breathing is best. They should try to use slow pursed lip breathing. Refrain from having sex right after eating or drinking alcohol. Try to choose less stressful positions, and then use oxygen if they're prescribed for it. It's really important for somebody with COPD to get appropriate amount of sleep. Their oxygen saturations may drop during sleep, and that hypercapnia leads to them waking up many times throughout the night. Some of the factors that interfere with this is that current tobacco use, depression, anxiety, medications, congesting, coughing or wheezing, or even sleep apnea. So symptoms can be managed with COPD, but it's not cured. If somebody has severe disease, we need to be sure to talk to them about end-of-life issues, advanced directives. We don't want to wait to talk to them until it's too late. Palliative care, end-of-life, and hospice are important to talk about in advanced COPD. Now, bronchiectasis, we're going to cover this very quickly. Bronchiectasis is when there's a permanent abnormal dilation of the medium-sized bronchi, secondary to inflammatory changes. And that can be from destruction of elastic and muscular structures, the bronchial wall. There's a couple different types. Cyclical process of inflammation resulting in damage, which results in that remodeling, or even colonization of microorganisms such as Pseudomonas, causes a weakening of the walls and pockets of infection. They usually have bronchial wall injury, which is causing that accumulation of the mucus and bacteria. And then that bacteria causes the neutrophils, which increases the inflammation and edema. And that makes it difficult for them to be able to get rid of that mucus and decreases their expiratory flow. The really big thing I want you to think about with bronchiectasis is that they're going to have persistent production of thick, tenacious, purulent sputum. And if they have hemoptysis, that's a problem. So when somebody is coughing up blood, that's when we're going to be doing things. And so with bronchiectasis, we want to treat those flare-ups and try to keep them from having declining lung function. Antibiotics as appropriate, SABAs and LABAs, corticosteroids, and then all that chest postural drainage. Remember that with bronchiectasis, this is often from things like COPD or cystic fibrosis. And so in that acute care of bronchiectasis, when they have that hemoptysis, you're going to elevate the head of the bed, put them in the sideline position with the bleeding side down if it's known, monitor the vital signs and respiratory status, and of course, a lot of those other things that we've talked about. They may need that increased hydration from the tenacious secretions, rest, nutrition, and surgical resection or lung transplant.